So how did the Care Oncology Clinic come about?
So the Care Oncology Clinic started because of a group of scientists and medical doctors who wanted to introduce repurposed drugs into the cancer space. And initially the driving factor was that one of the lead scientists for the group, Robin Bannister, his wife had developed metastatic breast cancer, and she had been on the usual standard of care, chemotherapy agents, radiotherapy, etc. And unfortunately didn't seem to be responding well to those. And he was able to find someone to prescribe some repurposed drugs, and she seemed to improve a lot better than expected. And so the feeling was that it would be good to explore this further. And so the group did a review of the available medications and then proceeded to narrow that down to a manageable protocol of 4 medications. And then wanted to go further actually and introduced this as a study in the UK, and so discussed and got approval from the MHRA to have this as a treatment clinic, but just as importantly as a research tool that could have data published through the MHRA, and therefore hopefully in the future influence prescribing practice via NICE and the NHS.
Mm-hmm. And so what is the metabolic approach to cancer?
So the metabolic approach to cancer is looking at the energy use of cancer cells and how cancer cells access this energy. In other words, it's looking at the environment that the cancer cell operates in. So if you kind of imagine the soil around the seed, and so the idea that actually if you change the environment or the soil that's favorable to the cancer cell, then that stops the growth of the seed or the cancer cells in this instance. And we know that there are straightforward molecules or components like sugar, for example, glucose, which are extremely important to all cells growth, but particularly cancer cell growth. So if you can limit some of that, then that changes what the cancer cells are able to do.
So why are you using repurposed drugs for cancer treatment?
So repurposed drugs are really useful in this space because these are drugs that have been moved from one condition to another condition in medicine. This happens quite a lot. And sometimes we come across these things by accident. And in the case of a drug like metformin, for example, which is one of the drugs on the protocol, a very clever clinician noticed that within a group of patients who both had diabetes and cancer, the patients with diabetes and cancer seemed to be doing better than the ones with just the cancer. And of course this didn't make any sense until they realized that actually it was the metformin drug that the people with diabetes were taking for their diabetes that was actually helping them not just with the diabetes but with the cancer as well. And so that then led to people exploring this further to say, well, why would this diabetic drug have an impact on the cancer? And then people took that and moved backwards to then investigate in the lab what pathways that drug follows and what pathways that might interact with in the context of the cancer. So repurposed drugs are really useful because they are already on the market. So in other words, you don't have to start from scratch to reinvent the wheel with a new drug. Part of my research work is to do with new drug research, going from the lab through animal testing, phase 1 to phase 4 testing, which takes a lot of time, on average 10 to 15 years at hundreds of thousands, sometimes a lot more than that to produce one drug from scratch. And of course there are a lot of patients who have the disease now, who have cancer now and don't have 10 to 15 years to wait for a new agent. So repurposed drugs are really useful in being able to get drugs which are already available, which we know a lot about, not just in terms of what they can do in cancer, but know a lot about in terms of their safety. Because those drugs have already gone through their phase 1 to phase 4 testing, and a lot of that is about safety. So we know they're safe, and we now have data that they work, and we can implement that into the system sooner rather than later.
So do you have any statistics from the patients that you've had at the clinic?
So it's been a very encouraging response. The clinic's now been going for about 4.5 years, and even within that time we've seen some really encouraging responses across the board. Statistically, we have data for one group of those patients, and the reason, unfortunately, for that group is that they have quite short timelines in terms of survival timelines. But it does mean that in the short space of time that the clinic has been around, we've been able to show statistically significant improvements. But the hope is that this translates to the rest of the group, of course, and we're seeing those trends happening already.
Are pharmaceutical companies interested in repurposed drugs?
I think it's difficult for pharmaceutical companies in general to focus on repurposed drugs. Generally, pharmaceutical companies focus on novel agents or new entities because they can have those patented. So it's a lot to do with the economics of how drug development works. So I work as a clinical research fellow at King's, and a lot of the studies that we work on are new drugs. So they go from the lab through animal testing and then go into phase 1 to phase 4 testing. And that's obviously a very good, comprehensive way of developing a drug for a condition, but it's incredibly expensive. So, often for oncology drugs in the region of several hundred, £1,000 per single drug. And it's quite time intensive as well. So, for a drug to go from the lab to the market, you're looking at 10 to 15 years of work to get to that place. And for a lot of people, that's just way too long if they have the disease currently. And so repurposed drugs are a really useful agent in this space because they then can actually cut a lot of that time factor out and cost. And so people can have access to drugs which are already in existence on the market and already have a lot of data behind them, not just about efficacy and how well they work, but also about safety, because all of those drugs will have gone through the early phases, phase 1 and phase 2, which are generally concerned with dose and safety, for example.
Does the field of oncology accept the metabolic approach to cancer?
Initially, the response to this was not always enthusiastic, in the sense that people didn't know a lot about the metabolic approach in the mainstream oncology world. But some of that is changing now. There are a number of studies which are starting to focus on metabolic agents, even within the NHS space or the MHRA approved studies like ours. And so there is an increasing acknowledgement that cancer is such a complex disease that a single silo approach, like the genetic approach or the hormonal approach, isn't quite enough for most cancers, and that there are other ways of treating this disease. A good example of this is the fact that there is now a huge emphasis on immunotherapy drugs, which 20 years ago was not really a factor in the mainstream world. And this is different from traditional chemotherapy agents. This is, in a sense, an acknowledgement that it's good to work with the immune system. So there's already an expansion into the fact that actually working with the larger individual systemic environment is a good thing. And we see the metabolic approach as another piece in the puzzle, complementing or working with everything else to have a proper comprehensive approach.
So why is the treatment at the Care Oncology Clinic not on the NHS?
The NHS gets its guidance, quite rightly, from an organisation like NICE, and they in turn will get their guidance from large randomised clinical trials. Generally, historically, this has been the approach. But unfortunately, for some conditions like cancer, it's very difficult to get large randomized blinded trials in certain settings, but also for certain drug treatments as well, like repurposed drugs. It can be difficult to get large randomized clinical trials for repurposed drugs for various reasons. Some of those are economic reasons, again, and some of those are just the practicality of the fact that these drugs are usually used as additional drugs or adjunct treatments, whereas in a lot of randomized clinical trials, the drug treatment tends to be given as much as possible in isolation, as opposed to part of a larger group of drugs, essentially. The drugs themselves are very cheap, and that's part of the point of the repurposed drugs, is that for the 4 drugs for a 3-month prescription, it usually comes to about £70 or thereabouts. And so, relative to thousands and sometimes tens of thousands and maybe more of traditional treatment, to shore up a really important aspect of the treatment. I think it's quite cost effective, really.
What is the kind of condition of the patients when they come to the Care Oncology Clinic?
So it's variable, and we see people at all different stages. In the early days of the clinic, people generally came in at the later stages of their disease. But more recently, we've seen people who have been coming in a lot sooner after their diagnosis in the early stages, which is preferable, because I think at the later stages it's more complex, because other things like the individual's organ function or the state of the immune system, etc., might be a lot more compromised at that point. So it is preferable to see people earlier, but we feel, along the spectrum there is still scope to help. But of course, if someone comes in later on, the success of the treatment may be only really to kind of stabilize things or kind of slow down the progression of this disease. Whereas if someone is sort of earlier on, then there's a lot more that can be done in terms of limiting recurrence or relapse, and therefore kind of impacting survival times more significantly.
How do you know that it's the drugs at the Care Oncology Clinic that are making the difference?
It's not just the drugs. I think the drugs are, of course, very helpful, but these drugs really are a piece of the puzzle. So they fit in together with other treatments that are ongoing. And so it's really about trying to be more comprehensive or more global in the approach, to acknowledge that there is a part to play for these drugs, of course, in terms of affecting the metabolic processes, but all the other aspects need to be looked at, including the patient's day-to-day, their diet, their appetite, their general well-being. But these drugs are certainly an important part of that.
So with all these repurposed drugs, why don't more people already know about the metabolic approach?
So it is growing in terms of the number of patients that are finding out about it now. Obviously, it's not on the NHS yet, and that's a massive factor. But it is already being researched through Cancer Research UK and other sort of larger, more mainstream entities. And so I think it's a matter of time before this will happen. But certainly in this country, if a treatment isn't officially on the NHS yet, then it is more difficult for individuals to find out about it. But we see that as part of our mission here is to get the information about these drugs, not just to patients, but also to clinicians and scientists and the decision makers at NICE and the NHS as well.
The kind of method of putting the conventional treatments with the 4 drugs and allowing patients to do all their other stuff, how fundamental do you think that is to the success of what you've been seeing happen?
The approach of putting these drugs together with standard of care, I think, is absolutely essential and fundamental to how well this approach works. Not just in the scientific sense, of course, where we are trying to cover as many different angles or bases as possible, but also actually just in the functional sense, or just even in the psychological sense for the individual, in that they're not being forced to make a choice, really. They're not being forced to decide one or the other, which can be a big decision for an individual to choose one way or another. So this is saying, essentially, we want to try and help you do all of it and give you as many options as possible and do that in a safe way. And so, one of the really difficult things for a patient who is suffering from cancer or some other diseases is the fear that they may not be doing enough to help themselves. And it's the same for families and friends, feeling that they want to make sure the individual has every single possible chance at treating this as possible. Now, if someone has to make a decision between one thing or another thing, that's an incredibly hard decision. But this is not that. This is actually, the opposite, if you like, to saying, well, actually, we want to try and give you the benefit of all the known, well-researched options available.
So what do you hope to see for the future of cancer treatment?
What I would like to see for the future of cancer treatment is an acceptance that historically the efficacy of or the success of certain traditional cancer methods have been quite limited, really. There's been some great successes, but clearly a lot of methods haven't worked as well as they could have for many individuals. And so for the future of cancer treatment, I'd like to see more openness to new methods coming in to join the existing methods. It's not to say that the existing methods are completely useless, of course not, but they quite often could use additional assistance from other adjunct or additional drugs like the metabolic approach, repurposed drugs, for example. But it really is about trying to say, we recognize that this is a multifaceted, complex disease, and therefore the treatment has to match that, and so be a multifaceted management approach as well.